right. Everybody, John and I were residency classmates. I just did the math in my head, John. Do you want to hear how many years ago we finished residency?
It's probably got seems to be it's got probably a two in front of it, two
Yeah.
something.
Yeah, we're at 22 years. Yikes, which makes us old.
Yeah.
So John and I were residency classmates, and you can correct me if I'm wrong. He went on and did a NICU fellowship, but he came to medical training already with his JD. And I believe you've gone on and done further education. Didn't you go on and do like a master's of bioethics or something crazy like that?
So it wasn't a master's, but I did for my my research kind of aspect of my neonatology fellowship. I did ethics training at the University of Chicago. So
I knew you had some more education. John can't stop getting educated. So he does a great job, though, talking about ethics issues in general when it comes to our world, and he has a pretty good understanding of the things that we deal with. So I told the guys that this was interactive and they had to be plopped and willing to communicate with y'all. So if you guys are plopped at a desk, throw your cameras on so John knows you're there. And I have to get a kid up and out the door to camp. So we're recording. I'll let him take over. Oh, Justin, we have quite the glare behind you. Holy cow.
all right. I did shower because I thought cameras would be on. So okay, that's good. I'm prepared. Um,
We're low key. So I'll let you roll. Thank you for joining us as always. It's much appreciated.
no problem, no problem. Yeah, so this is I've done this for several times, and it's always this is nothing. It's not a big part of your boards or anything like that. So it's really just a I think for a time to kind of step back and think about the kind of moral and ethical challenges you face, which you actually face every day. But maybe get a little bit of a bigger picture of it. So yeah, I have no set agenda or anything like that, but we can kind of start by going back to your basic ethics training from whatever class you took in med school, or and talk about that in for pediatric ethics, which is different, and that's I think a big difference in what's the youngest age that you guys see in your clinics and stuff.
I'd say around 4 years old is the youngest I've seen.
Yeah,
Four,
two, three, somewhere around there, at least right now.
two or three, okay. And then what's the oldest?
103 for me.
Plus, yeah.
Okay, so you really kind of span the so the ethical considerations are going to be very different, for for all those ages. Okay, and so when we go back and first of all, what is ethics? To me, it's the big picture of it is sort of just because you can do something, should you do it? Sort of that's the and again, you have busy clinics, you're running around, you don't always know that you're incorporating those kind of decisions in there, but that's a big part of what ethics is. And so ethics has to be part of societal constructs as well. And so that's where kind of like my law background can be helpful, and it's because it's not just it's about the doctor-patient relationship, but it also is about sort of what society says about it too. And especially when we talk about informed consent, there's an ethics aspect to it and kind of a legal aspect to it. But and then the reason I bring up the social constructs is because it's a lot of what we're talking about is sort of the Western ethics view of things, and it's very different in other parts of the world. But when it comes down to the kind of the ethics in the U.S., the main issue, there's sort of four big principles that we sort of base our approach on, and we'll kind of discuss those. But the first one is this concept of autonomy. Okay, you guys have already heard the term autonomy, I assume. Okay, and what does it mean to you?
Sorry, I'm locked. Basically allowing the patient to make their own decisions and kind of see the data and pick what they want.
Okay. And yeah, I mean, that's basically, autonomy is basically this concept of that a competent adult gets to decide what happens to their body, right? Or autonomy is really about sort of control over your body, control over your decision making. And that's, again, that's something you're incorporating in your everyday practice, especially when you're dealing with the adult patients. But the reality is that's not how medicine was practiced for most of history, right? That most of history, it was actually the opposite concept of this concept of paternalism, right? Paternalism meaning, father knows best or the doctor knows best. And so the doctor would even think about asking the patient about what they needed. They would just do what they thought needed to be done. But that's obviously not the world we practice in now. So autonomy is really probably, I'm not gonna say the most important concept because they're all but it's the one that I think comes into play for you every day in the sense of informed consent. Informed consent is the mechanism by which autonomy is practiced in medicine today. So we'll talk some about autonomy. The next one is this concept of beneficence. Okay. And tell me what beneficence means to them.
Be doing what's best for the patient or whatever benefits the patient.
Yeah, exactly. It's sort of, put simply, it's sort of a do good, right? You're supposed to, and there are all sorts of, conflicts in medicine that we have to be aware of. And there are, very, every week you'll read about physicians who commit really heinous fraud where they'll do unnecessary surgeries. They'll bill for procedures they didn't do, or things like that. So, but it is supposed to be the idea that you're supposed to do what's right for the patient. So, I'm gonna, as I said, I'm not, I played high school football, but since then I haven't had a lot of interaction in the sports medicine world. But the idea of you can go, well, I could inject this knee, or you guys do injections? Okay, so you said, all right, I can inject this knee and I'll get $200. Maybe that's a fantasy. Maybe you'll get like $5. I don't know, but all right. Or I could, send this kid to physical therapy and I won't get any money. So I'm going to inject the knee because, I really should spend more time with this patient, but I got to go, things like that. So there are lots of conflicts that we have in medicine, but the beneficence is the idea that we're supposed to do what the right thing is for the patient. Okay. The third concept is non-maleficence. And what is that? What's that concept?
Basically the idea of, in my mind, is like kind of the do no harm, like the idea of you're trying to not do anything, to harm the patient.
Yeah, and it comes, I think that's part of the Hippocratic Oath, even like first do no harm or something, right? So, and again, these are all principles, right? We do harm every day. I'm sure a lot of your therapies are very painful for your patients. You're doing it to help them, but even the idea of the injection, right? You're sticking a needle in someone's knee. That doesn't sound very fun, so we recognize that, in my world, in the NICU, we do harm every single day, the procedures we do to patients. So it's not, it's really do no harm is not actually do no harm. It's really about trying to minimize the harm you're doing, or doing harm that has a reason. Okay. You're supposed to do things, the things you do that are harmful are supposed to be done for the benefit of the patient and not for other reasons. And then the last of the kind of four principles is this idea of kind of justice. Justice is it's funny. Justice did not really have a big role in ethics, in Western ethics, for the last several years. When you would hear about it, really used to be just organ allocation, right? There's only one kidney and two people, and who gets it, and you're supposed to have a fair system for organ allocation. It was really changed in the last decade or so. First, the pandemic became, was a very scary time for concern for resources, where, you know, in the beginning of the pandemic, where it was like, okay, we're not gonna have nearly enough ventilators, and so, you know, we have to scramble and say, well, how do you fairly allocate scarce resources such as ventilators, and things like that, and that kind of came around. And then obviously in the last several years, there's been a lot of conversations about sort of equity and other, you know, fairness and distribution of resources has come, you know, a lot farther um, than a lot more conversation about, certainly, than in the last, so again, in the last several years, and maybe in the, I don't know, do these kind of things come up in sports medicine, or is it?
Wouldn't say they come up regularly. Um, just general discussion with attendings and everything, but definitely more for board studying. You know, that I feel like that's where I see it more often. And then just kind of, I think these topics or terms are addressed kind of built in to the conversations that we might be having, where we're
Right.
talking about it and we don't realize we're talking about it.
Sure. And obviously you do have, I mean, you see patients who clearly have different resources available to them, and even, you know, I'm sure, you know, different school systems you work with have very different, you know, I went to Hawken, which, you know, was a very well resourced private school. And, you know, I get their emails and I see they have, you know, a sports psychologist assigned to, you know, that they pay for it to come to Hawken. And I'm like, okay, well, I'm sure there are other school systems where they don't have enough equipment, you know, let alone access to a sports psychologist. So, you know, again, these are issues you'd want to be aware of. They're not, you know, you do want to try, you know, in general, we try not to, you know, we try to not use that as a focus of our decisions, but there are conversations of it, and that is in pediatrics, at least, that is where there's a role for, you know, for advocacy, as well as a part of it, to, you know, say, hey, let's, you know, let's get you know, defibrillators at every school, not just the rich schools or things like that. That's, you know, stuff like that. So that's kind of the overview of those. Is that sort of everyone's understanding, or anyone? And so going back to that, I'm presuming, but again, I don't do what you do. So, you know, I'm presuming that, you know, probably the one that comes the most into play for you on a daily basis is going to be this idea of the autonomy issues, and you know, especially because you're dealing with all different age ranges, you know, it's you know, that we have to take into account the fact that, so technically, you know, the age of consent in Ohio is 18, right? So that's the legal, you know, if you are treating a minor patient and it's not a, you know, a life-threatening kind of situation, in general, you need to get consent from the parents. However, and that starts at 18. It is not, I'm not gonna say it's arbitrary, because it, you know, there are reasons why they choose 18. But at the same time, it's not a like something magical happens when someone turns 18, right? And it just occurred to me that, you know, my senior year of high school, when I did football and wrestling, like, I was 17 my whole senior year of school, but some of my friends were 18. And I don't think any of us were different. We all were different maturity levels and everything like that, but legally the 18-year-old could consent or refuse treatment, and the 17-year-old would need their parent, for the most part. So the consent there is the aspect there, but you know, when you're dealing with, especially when you're dealing with adolescents, there's this other aspect, this other idea of assent, right? That you know, and assent is the giving permission to do that therapy. And even though they can't consent, that, you know, again, when you're 17, you should have a pretty good say about what happens, and take that into account. when you're 4 or 2, you really have no, that there's no real capacity to consent or assent either. And so this is a it's a continuum, and exactly when someone gets that capacity to provide assent is there's no right line. I mean, the in general, when you read about it, you'd say 7 might be the earliest someone could really have any ability to do that. But especially I assume if you're dealing with a 6 or 7-year-old, it might be again, it may be someone who's in gymnastics and been doing it for years and years and years, and maybe they do have some understanding of that aspect of things going on. So what are kind of the you tell me sort of what are some of the challenges you guys are facing with consent? Is it what are things to keep in mind?
One issue that I may run into, I've told these other guys about it too, like we cover high schools, and so we're in the training room seeing them, or we're covering their games, and majority of these athletes are not 18. And if we think they see them in the training room and we think one treatment route or one diagnostic approach is appropriate, we still can't pursue that until we've talked to the parents. And so we either call the parents or we have them come into clinic to be seen. It doesn't always work out that way. And then there's this kind of gray area of you're still giving recommendations, even if it's just, oh, these are some exercises that I think you should start doing. And that's still technically an intervention that you're giving them, or a treatment. And you may not get like formal consent from the parents if I'm just saying, hey, these are some exercises you should do for your rotator cuff. And if that's all I'm offering, a lot of times I probably would not call the parents. So there's kind of this light gray area. Granted, if we're putting them on a medicine, ordering a test or something like that, we usually will call or have them come into clinic to be seen.
Right. That makes sense. I mean, the other aspect of consent is actually, which is another thing that is they do also have to, to provide consent, you have to be a competent adult, meaning you have to also have the understanding of the information provided in order to make a decision. And that, I don't know if that ever comes up too, where you're like, well, they can't really, they're not really showing understanding, or they're, I think the big thing, and this is in the past few years when I've talked to the sports medicine fellows, obviously big thing in your world is concussions. And concussions, again, a decade ago, no one was talking about concussions. It wasn't and then obviously it became a huge aspect. And going back to, the 80s when I was playing high school football, I mean, a concussion was, you got your bell rung and you were back in there. I remember a guy who didn't know where he was, and 10 minutes later, he was back in the game. It was not even, it just wasn't, no one's paying attention to it. And now it's becomes, your protocols seem to be changing all the time from my, whatever I read. But I could see, especially for a high school athlete who's, desperately wants to play, that they may not, they may be making some, I don't know if inappropriate decisions is the right thing, but they may be putting their health at risk for the short-term gain of being able to play. Is that something you guys are facing a lot?
And parents sometimes will be that way.
Yeah, we get pushed back on the sidelines sometimes.
And so, that's, and then, again, it's I don't know if you see this in the high school level or not, but there's also, obviously, you read about, in fact, I'm just reading about a sports medicine, American orthopedic surgeon who was suing because the team had thrown him under the bus because they said, well, your recommendations are, the coach wants the players back. So there's that contrast. Now, I mean, I suppose for you guys, you have at times you have the coach, you have the parents, and you've got the player, and everyone's interest may not align.
I think the athletic trainer is another part of that as well.
And the athletic trainer, okay, that's a very good point, so, you know, and of course, you guys are part of the, you know, the sports medicine at UH takes care of the Browns, for example, so, you know, you take, I mean, that's even, the pro athlete level is, the stakes are even, you know, then you have the public aspect of it too, right? There's lots of pressure from kind of the outside world. So how do you guys work through these conflicts? I guess would be.
I think, well, I mean, I don't know about the other guys. I'm lucky in that the trainers I work with are all pretty supportive of me. They're kind of are like, I'll just, whatever your decision is, I'll support it, is kind of their standpoint for most of the time, which is super, super helpful because, usually, these trainers are with these players every day. And so they have a lot better relationship with the players and with the parents. And so they're really, really helpful in getting through to stuff like that with the parents. But, and it's that about delicate situation of where you got to kind of try to explain to the parents of like why you're saying what you're saying, but at the same time, like, don't be a pushover and be like, okay, yeah, you're right, sure, whatever, they can just play. It's that balance of like, this is why, but if they're still just being ridiculous, you have to be like, I'm sorry, like this is, this is what's happening kind of thing.
Right. And then are you guys now, because I think the other thing, one of the other aspects was a lot of times, and let's, you take the 18-year-old, and again, from the ethics, we're really not, the law is the law. But, again, when you're in the locker room and one kid's 18, the next is 17, they're not really that different in the same grade. But, it's the interesting thing is when they are 18, the only aspect of it is that they have the right to completely ignore what their parents say and ignore what you say. That's, they can, it ultimately is their decision, whereas for the 17-year-old isn't necessarily. I suppose, I think, tell me if I'm wrong, but I think one of the other aspects maybe now with things like concussions is that they actually do need your clearance to come back, right? There is I don't know if that's a state law or is okay, I know.
It's a state law. You have to go through the 5-day return to sport progression before you can go back to playing.
Okay. So
something again that's very helpful for us, I think, because that it's a good fallback for us of like, oh, sorry, like, my hands are tied, you legally have to do this. So I think that definitely helps because it kind of puts some of the blowback onto that.
Right. And then that's really good because that's a good example of society, right? To the extent that you say the law is reflective of societal priorities. Yeah, society saying, okay, we're not going to even let you in the concussion protocol say, yeah, but this is the big playoff game. And if I don't play, I'm never getting that back. So I agree with you. In some ways, it is helpful to have the backing of, okay, this isn't, they can't pressure you in a sense because you don't control it, and that makes it easier. And that is an aspect of, it's I don't know all the background of it, but usually there is advocacy behind that. Someone's kid had a real bad out with a concussion, they go to the state, they say, hey, or you guys group as Association of Sports Medicine people, or whatever it is, to get things like that passed. But it is, I do think, your field, the stakes do seem to be higher now. It seems like kids are focusing more from a younger age on single sports and things like that. Is that what you guys are seeing?
Oh, definitely. We're seeing a lot of specialization.
And again, now that as college becomes more and more insanely expensive and things, for many families, it's like, well, this scholarship, getting a scholarship is a ticket out, so to speak. It's right, and but I don't know, are those, do people say stuff like that to you directly, or is it more of the undercurrent of, in the background?
I think for us too, we have to kind of ask those questions, and that's something that I've gotten better about throughout the year, especially in clinic, where you talk to the patient about the injury that happened. I mean, there's a whole process that goes through your head of how do I diagnose this? How do I get to that diagnosis? And then what do I treat them, or how do I treat them? And then you also have to ask those questions of what are your plans? What are your goals moving forward? Where it might not be interested in pursuing college sports. And that really does at times change our treatment. If there's something, I'll just use like a labral tear in the shoulder as an example, and somebody who's not playing like a throwing sport or overhead sport, where they could probably get by with a torn labrum through their senior year, knowing that they need surgery down the line, versus this is the start of your senior year. You already have a scholarship or you have plans moving forward, and that's really important to you. And maybe they do have a profession to be a professional athlete in their future. And so they might jeopardize their career if this goes on untreated. And so then let's take care of it right now, knowing that we can rehab you, we can get you back for your freshman year of college. And so the timeline with that kind of changes, and our treatment plan really changes too. And I think it's important to talk to the patient and their families about what their options are. And then I'll even just say the word firm straight out with patients of this is shared medical decision making. We need to kind of come to an agreement here on what your goals are, what you think would be best. And you try to lay out what the timeline looks like for each outcome or treatment plan that you have. Those appointments tend to take a little bit longer.
Yeah. Yeah, and you actually hit on something that is, that is shared decision making is kind of the current buzzwords for informed consent, that it's, and in the, when you discuss consent, you really do want to, go back to the requirements of informed consent are actually, there are several different aspects. The first is what you want to do and why you're doing it, the benefits of what you're doing. The next is the risks of what you're doing, since everything obviously does have risks. And the third is, and risks, you always need to talk about things like, this may be career ending for someone, that things that are relevant for that patient. The third aspect of it is alternative. Okay, you could do this, or you could go down this path, and then you're supposed to talk about the benefits and risks of those alternatives. And then the final aspect is the what happens if you do nothing, right? Because that's always really an alternative, is not to, and well, what does that look like? So yeah, you guys are probably already doing that, but in the terms of what are the requirements, both ethically and legally for informed consent, that's sort of where those are. And it is absolutely not. I mean, the one thing to be very clear is that informed consent is not just about that signature that you get on the form. That and so to the best of your ability, and we're always balancing, you can't spend your whole life documenting. But at the same time, in the, what's going to matter in the sort of legal world is going to be that how are those discussions documented at that time, as opposed to later.
I think it's something, an interesting one, going back to the consent side of things, is, from the very adult side, had a couple patients with dementia, which kind of like throws a weird wrench into things. And one example that really sticks out is that I saw a patient where who was like brought in by their daughter, I think. But when I went into the room, the daughter was in the restroom, and I didn't see anywhere on the chart anything about dementia or anything. So talking to this lady, she seemed to fully understand. I was like, hey, I saw you here for knee pain, blah, blah, blah. She's like, oh, my knees actually feel pretty good. We had done injections on her, in the past, and she's like, oh, my knees feel great, blah, blah, blah. went this whole thing, examined her. She's like, oh, they don't really hurt when you push on it. And I went out, told this all to my attending. And then when we came back in together, the daughter was back and he was like, oh, I hear your knees are feeling great. And the daughter's like, absolutely not. All she does all day, every day is complain about how bad her knees hurt. And the daughter's like, we absolutely need to do injections because like she's driving me crazy with she's just constantly complaining about it. So, that was definitely made me kind of be like, oh man, like
Right.
I couldn't even tell, like, talk, like I said, some patients you talk to them, you're like, all right, you're definitely like, not all there. But this lady, like, was answering very appropriately, like, seemed to remember everything that we were talking about. And so that was definitely an interesting one.
Yeah, that's that's that should be all over the top of the chart, you think, but apparently
Right.
not. For sure. Yeah, that's that. So did you end up doing the injections, I assume?
Yeah, yeah,
And you got the consent from the daughter?
yeah.
That's our word. Now the interesting thing, and that you cooperate with the injections, because then the other thing is sometimes you have that situation and the patient is not cooperative, and then it becomes
Right.
the harder circumstance for sure. Okay, so I think consent is obviously a big part of what and the autonomy aspects are big. What about some of the others? What about the kind of doing good versus doing no harm? What kinds of what are the ones that come to mind for those kind of decision making? Is it surgery versus rehab? Is it
Yeah, I think with the do no harm portion, we do often do injections where like everybody asks if it's going to hurt and we kind of brush it off, but we try. I mean, I always try to explain, it's going to hurt. We're putting a needle through your skin, but in the end we're hoping the juice is worth the squeeze and you're going to get some benefit down the line. So you mentioned that earlier about the injections. We're poking somebody with a needle, but it our idea overall is to get them better in the long run, which kind of is easier to swallow after you've done a bunch of them. But if you think about it from just a one-off, can be a little
right?
foggy.
Yeah, that's again, there's always and then there it's funny there the it's there's ethics in every type of decision. You just don't always think about it, but and there's again there's training ethics is another thing. I mean, you guys are all in, how long is your fellowship?
1 year.
1 year. Okay, so your skill, you got to start somewhere. So your skill at doing your first injection in July is probably very different than your skills now when you're finishing up in the end of June. But that's again, that's just part of the nature of training. In medicine we try and help that with by having supervision and simulation and all those kinds of things. But there's no question that again, going to the pro athletes, they tend to go to a select few surgeons, right? Because they're like, I'm not going to go to someone fresh out of training. I'm going to the person who specializes in this, or things like that.
I think one other issue that we run into, kind of going off of what Tyler said, I know we've been talking a lot about injections, but that is a really large component of what we do, is that there are so many patients that come in when they have received injections in the past and gotten relief, let's say from cortisone, and then over time that relief starts to wane and we have to make the decision of, okay, these aren't benefiting you anymore. In fact, they can be harmful, especially if we're injecting near a tendon. We can start to see degeneration of that tendon if they're getting frequent injections over a long period of time, versus, like Tyler said, is the juice worth the squeeze? There's a lot of patients that get 2 weeks of relief knowing that we can't repeat this injection in 3 months. And so there's going to be a 2.5-month period where you're still in pain, and we've just poked you with a needle and potentially caused some degeneration of the joint or tendon, whatever it is, or cartilage. And having that conversation can be especially challenging because there's some patients that are like, I don't get it. I don't get why I can't get this injection. And then that's when it comes in where we have to talk about the alternatives, including like just other options for injections versus a less invasive type of procedure or like surgery. And that can especially be challenging because a lot of the patients we're seeing are trying to get a non-operative approach to their management when conservative strategies have failed.
Right.
And kind of dovetailing off that, there's one patient we see often who we give injections to in many joints. And whenever they come back in, they're like, "Oh, we only got a couple months or a couple weeks of relief." And last time I saw her, I was like, "Well, it's probably not worth doing the injection." And then she's like, "Well, that is 2 weeks of my life. That is great." And she doesn't have any other options. So it's kind of one of those things like we're not supposed to do this if you're only getting a couple weeks of relief, but she is very happy in that time and understands that she can wait or has to wait. So it's kind of like a weird situation, but she wants to do it. So
And
Right,
we
right.
especially make those exceptions for those patients that are like older, or just really not a surgical candidate anymore. Yeah, or we're kind of weighing that, okay, quality of life at this point is more important. Yeah.
Sure. Sure, but then it's but it does have a cost long term, right? It's that risk versus, you remember the famous marshmallow test? Well, they offered the kids, you can have one marshmallow now or two later. And they all choose the one now, right? They all
That delayed gratification.
delayed gratification, not something there. Um, and then of course there's and again it's sort of bigger, I definitely in my world of premature babies, but also there's in some ways it's the hospital systems, when you look at the advertising, and there's been a lot about the Sports Medicine Institute at UH, it's we can fix everything, right? That's sort of the message that's sent to patients, and then they come in and think, what do you mean you can't? Yeah, what do you mean there's no treatment for that, or there's no injection or things like that? And then I think, again, a big part of your world, I assume, is adherence and compliance to kind of your therapies, right? That, I think the unique thing in sports medicine is how much it depends on the patient putting in the work to help with the results. Is that true?
Absolutely. Yeah. I mean, like there's so many times where the best treatment is some physical therapy. And I feel like patients are always like, "Ugh, physical therapy." And I've had several patients who they crack me up because they come back for follow-up. And I had one guy in particular who came in for back pain. We had him do 6 weeks of therapy. He came back. He's like, "I gotta tell you, I thought that was gonna be a bunch of crap." He's like, "But I'll be damned, my back feels so good now." So and we're like, "Oh yeah, it's like almost like we did that for a reason." But you know, it's like it's so important for these things. And I tell patients all the time, like, yeah, I'm like, we tell you these things for a reason. We don't just tell you them just to like say words. Like we
Right, right,
there's actual method to our madness. But a lot of that comes back to like patients sometimes choose not to accept a diagnosis, and that definitely makes things really difficult. I think something that we see fairly often too is, especially like our middle-aged population, come in with an achy joint, and we tell them like, "Hey, unfortunately, like you have really bad arthritis of this joint. There's not a whole lot we can do here." But they're like, "Oh no, I don't have arthritis," or
right,
like
right,
you know, so
right.
it makes our job really frustrating when that happens. And we see it too, like especially knees. For whatever reason, people get like so obsessed about like, oh, what if I have a meniscus tear? We're like, you have severe arthritis. Of course, you have a meniscus tear. Well, can't we do surgery for that? And it's like, no, it doesn't work like that. And so that's one of those like frustrating things that kind of we get stuck in. Um, you know, but really at the end of the day, like a lot of these things, the patients have to buy into the treatment plan and actually do the treatment plan. Otherwise, the I think something that I'm sure is frustrating for the other guys too. It's really frustrating for me is like, we tell these patients like, here's our treatment plan. They come back in a month, they're like, oh, I'm not any better. Well, did you do anything that we told you?
Right, right,
Well, no,
right.
I didn't do anything. like then of course you're not better because you did absolutely nothing that we told you to do.
Yes. Yeah, no, 100%. And it's, and again, looking back and just, keeping in mind, because you do, you're going to go in, you're going to go to clinic and you're going to have a 40-year-old and then you're going to have a 6-year-old. And then you're going to have but it is very, you go back to you recommend therapy, 6 weeks of therapy and they're 25 and they don't go, well, that's on them. If it's a 6-year-old and the parent doesn't take them for therapy, that's, from the ethical standpoint, that's different, right? That's, that's not the 6-year-old's choice that they've made. And so it is a different thing. And I don't know in your world that you see a lot of, in my world where I deal with babies, we unfortunately do see, medical neglect. And that, parents are required ethically to do that. I don't know that county's ever going to take someone's custody away because they're not taking someone to, to their.
I had a case this week. So on Wednesday, I had a patient come in who 6 weeks ago had an acute ACL tear, playing basketball, and went to the Rainbow ED. They got X-rays. I mean, he actually like pulled off a chunk of bone from between, in this intercondylar notch. And ortho saw him when he was in the ER and was like, "Hey, you really need to come, see us outpatient so we can get an MRI." And they made an appointment before they left, but then like mom just like totally no showed the appointment, and then like didn't do anything for this kid. So this kid's just been chilling with a torn ACL for a month and a half. Mom finally brought him in to see us on Wednesday, and that was the first thing I thought of, was like mom was just so nonchalant about the fact that this kid's just totally deficient, and like he is just like a big athlete. He loves playing. He plays basketball and football and stuff, and he like he's complaining about how unstable his knee is, and he like tried to do a basketball practice, and like how his knee is just all over the place. And but yeah, I think that's something I think we see with the piece.
Yeah, I mean, well, it is, if it gets to, life or limb threatening, that, that can be in a situation where they do need to take it seriously. I don't know, county is just so overwhelmed and stuff like that, but it is supposed to be. And speaking of life threatening, I mean, how much, eating disorders are another area where I think you guys are involved with. Is that something you guys are dealing with a lot in current day, or not as much, or?
I mean, I would say it's very prevalent. I don't say we directly deal with it a ton, other than I would say probably our college students would be where we deal with it more.
Yeah, clearance. So like yesterday, I had a kid with a history of a eating disorder who's trying to get cleared to do cross country and track for college. And I did her physical yesterday. She's an incoming freshman. But it's interesting, like she's like 5 years out and feels pretty comfortable. So, like a lot of times if they're more recent, we actually do participation contracts with them. So it's not uncommon for like at each school to have like one kid maybe who's got a participation agreement where, here are all the steps that you have to follow in order to participate safely.
Yeah, but I mean, look, eating disorders are not those are also potentially life threatening, right? I mean, they're.
Yeah. Yeah. So, but we put criteria like in the participation contract about like where they need to be in terms of participating. And, first and foremost is they have to be, through their treatment, they have to be medically clear. They have to be doing ongoing counseling. They have to show that they're attending their ongoing counseling. They have, usually we'll do like periodic blind weigh-ins for them. But it just depends how far out they are. If they're acute, then a lot of times they are restricted because of the medical issues with them participating are potentially more threatening. But when they're like a year or two out, or if they're just finishing up treatment, then a lot of times like a participation contract is usually what we do. And kids for the most part do pretty well with that. It's all a matter of like getting them into the counseling though. Like 90% of the problem is when kids show up and they haven't been identified as an eating disorder and it emerges during college, and then you have to restrict them because they can't participate, and then you have to get them treatment. Those kids are always obviously more challenging. The kids who've been through the treatment, it's more a maintenance kind of thing.
Right.
Yeah.
Right. So,
But yeah, I mean the whole college clearance thing, just nails home all those so many ethical points, right? Because you're trying to do what's best for the athlete while at the same time making sure that you're keeping them protected, but also making sure you're protecting the school in some ways from liability issues. So first and foremost is the athlete, but then you also have to keep everybody else in mind, no matter what the problem is.
right. And that's actually probably the last, another big aspect that we sort of touched on a little bit in terms of, we said, you're a lot, you may be pulled in different directions by the coach, the trainer, the athlete themselves, and their parents. In you do need to be aware in some ways about how it's going to be perceived when your paycheck comes from the team.
Yeah. Did you see, I can't remember who I was talking about. Maybe it was Tyler we were talking about. Did you see the Penn State legal case recently where the
Yeah.
team doctor was awarded millions of dollars, the orthopedic doctor? Did you see that, John?
Yeah, because they threw him under the bus right after.
Yeah. Yeah. The coach like completely pressured the orthopedic doctor to, he was like consistently trying to interfere with clearance issues. And the coach reported him multiple times and the school didn't do anything about it. And then they turned around and didn't renew his contract. And he like successfully sued and got over like $5 million. So, but I think you guys, you've only been doing this in schools a year. Have any of you not been pressured by a coach yet for clearance?
Definitely have been.
Yeah. That's like the most common thing ever. Right? Like I have to have this kid, doc. Like, I have Ursuline kids show up to get cleared and their coach brings them a lot of times. So, when you put the coach in the room with you, it's like a whole different dynamic. So, but kind of always getting back to John's point of you have to do what's best for the patient is the most important thing.
Yeah.
And I do think like the Penn State lesson's important, right? Like if you're at an institute where you're working for somebody and you have a coach who's interfering in any way, shape, or form, like you need to take that up the chain and document it.
Right. Going back to the base when we started, the basic principles of ethics and the Hippocratic Oath and things like that. It's like it's the doctor-patient relationship. That's always the key. And the reality is, especially, and there are different pressures at pro sports versus college, etc. But at the same time, you also are dealing in those situations with someone who is not just looking, they're very focused on the next few years of that sport, but you as a physician have to think about their entire life and what they're and it's a really it's a really interesting ethical thing in some ways when you think about like pro football players who like I'm not gonna say uniformly get CTE, they don't, but it's clearly a fair number of you end up with shortening their lives, right? I mean, and having kind of permanent brain damage from that sport. It's going back to the bigger picture, the American Academy of Pediatrics, right? If I remember correctly, it actually reminds me, Susan, I remember I actually gave a talk at the American Academy of Pediatrics meeting for sports medicine. You remember that? I remember that. I think that was on concussions back when concussions first became a big thing.
Yeah. I don't know what year was that?
It was in Orlando, I think. I can't remember.
Oh, was it the Orlando year? Yeah. Okay.
But anyways, the American Academy of Pediatrics, if I remember correctly, like actually says kids shouldn't box. Is that correct?
They've kind of backed down a little bit.
Little bit.
I mean, it's touchy because the problem that was happening was pediatric providers were providing care at boxing events, and they couldn't get liability coverage because the AEP was saying boxing should be banned. So, the position stands, I'm actually the fun person in charge of all the position stands and clinical reports, and the boxing one got, retired at one point. So like it just essentially expired. And so the position no longer exists in either direction for boxing. But don't worry, we're working on what will probably be an incredibly controversial release on a statement involving tackling in the future.
Ah, all right. Well,
Been 4 years in the works, actually 5 years. It started getting written in 2019.
yeah, I used to chair the committee on medical liability and risk management, so we had to look at every single policy that came through from the AAP. That was fun. But but even getting back to when it did say that, I always thought that was a little bit short-sighted, might be, because it's not, again, it's not that there aren't risks to boxing, but a lot of the, at least my understanding, a lot of kids who box, it's not a matter of they're boxing or not boxing. It's boxing was an escape for them from the streets, right? It was like it's like all sports have risk. I mean, you wouldn't have a job if they didn't, in a sense, right? I mean, it's again, you have to weigh risks and benefits, and then again, you do want to weigh in that the autonomy aspects, and again, we're not just talking about that when you turn 18, it's not just about consent to medical treatment, right? When you're 18, you can choose to go skydiving, right? And some people are gonna say, hey, I'd love to jump out of a plane. Let people go, no. Not gonna, so we do there's lots of risky things out there, and we allow people to do that. So, but I think, this was, as always, this is really a enjoyable hour for me because it's not the usual stuff that we deal with in the ethics committee, or we don't get a lot of ethics consults and things like that, but it's a good reminder about that the ethics of the everyday, and gives you guys a chance to step back from, and think again, because you really do have it. You are in a unique, I just deal with babies. I deal with some teen parents, but you're dealing, again, you're going to a clinic and you're gonna have the 6-year-old and then the 40-year-old and then the demented patient you mentioned and everything like that. So it's good to get kind of these big picture, to take a morning to just talk about them. Was there anything else you guys wanted to talk about, or?
No, we appreciate your time greatly, John. I know it's valuable, but it's, I think, always nice to do this near the end of fellowship for people, because they can then kind of reflect back on all their, different situations they've come across in the last year and kind of leave fellowship with it fresh on their mind. So it's a good time of year to do it.
All right, wonderful. All right, well, I wish you guys all the best of luck. And,
Thanks, John. Have a great day.
Thank you
all
so
right,
much.
you.
Bye.
Bye.